Bismillahirrahmanirrahim. Pathophysiology of parathyroid hormone is discussed in this video. Insufficient secretion of parathyroid hormone by the parathyroid gland due to surgical removal, autoimmune damage, or genetic defect will result in hypoparathyroidism. So the pathophysiological effect of this condition are decreased osteocytic resorption of the calcium and decreased osteoclastic activity. Almost completely, these osteoclasts are inactive. So this will result in decreased calcium release from the bone, and there will be uh, strong bones resultantly. So it is also associated with low serum calcium concentration, and if this gland is removed suddenly during surgery or by any other mechanism, there is about the effect exerts in about 2 to 3 days, and there is blood calcium concentration drops from normal of 9.4 to 6 to 7 milligram per deciliter. While the phosphate concentration it increases, it often doubles. The normal of phosphate is 3.5 to 4.5, but a serum concentration it doubles. So it is responsible for integrity of the bone. The bones remain strong because calcium and phosphate are not removed from the bone, and hence the resorption is suppressed. Clinically, it will result in tetany. The low calcium level cause increased neuromuscular excitement or excitability, and this tetany is basically, we have already discussed, already seen that this is painful muscle spasm, and most dangerous of muscle spasm is laryngeal muscle spasm, and this laryngeal muscle spasm may obstruct the airway that will result in respiratory arrest and finally death. So to treat this condition, calcium supplementation, active vitamin D analogs such as calcitriol are given to improve the calcium absorption, and parathyroid hormone replacement is also given in some cases. The mainstay of the treatment is vitamin D. However, parathyroid hormone replacement can be given. The parathyroid hormone is rarely used, although it is naturally missing hormone. Because this hormone is expensive and its effect lasts only for few hours, and there is tendency for formation of the antibody against this hormone. Then the vitamin D therapy, this is the mainstay of the treatment for the hypoparathyroidism. High doses of vitamin D are used up to 100,000 international unit per day, usually given with 1 to 2 gram of calcium daily. And the goal is to maintain uh, calcium ion level in the blood. And there is also another treatment is activation of 125 dihydroxycholecalciferol or calcitriol, that is the most potent and faster acting, and this treatment is used when the kidney cannot activate regular vitamin D. So there is a risk of hypercalcemia due to strong effect, and it requires close monitoring. So the overall strategy is to rely on vitamin D and calcium supplementation. However, strong monitoring or careful monitoring is necessary to avoid overcorrection. Primary hyperparathyroidism is the abnormality of the parathyroid gland that causes inappropriate excess parathyroid hormone secretion that result most commonly due to a parathyroid adenoma or the tumor of one gland, most frequently seen in women, especially after pregnancy and lactation. The hormone causes excess uh, bone resorption via osteoclast activation. There is also increased extracellular fluid calcium concentration, that is hypercalcemia, and decreased serum phosphate due to increased urinary excretion of the phosphate level. So bone effects of this hyperparathyroidism, uh, they are various. In mild cases, there is compensatory new bone deposition, while in severe cases, there is bone degradation and development of fracture with even mild trauma. It may also associated with pain and deformities of the bone. And on X-ray, there is presence of extensive decalcification areas, cystic degeneration. So this gives it a term that is osteitis fibrosa cystica, that is extensive bone decalcification, punched out cystic lesion that are filled with osteoclasts or giant cells, and these weak bones are prone to fracture and deformities and pain. There is also attempt by osteoblasts to repair the bone that is associated with increased bone turnover and increased alkaline phosphatase in the plasma. That is an important diagnostic clue. So key lab findings are increased parathyroid hormone, increased calcium, and decreased phosphate. And alkaline phosphatase is increased due to uh, bone turnover. So we have seen previously that the calcium levels in the blood are tightly regulated. So if the plasma calcium rises to 12 to 15 milligram per deciliter, a range of system-wide symptoms can develop due to calcium stabilizing but ultimately depressing effect of excitable tissues and muscular function. So there is nervous system depression, lethargy, fatigue, and slow reflexes. There is also somnolence. In severe cases, confusion or even coma may develop. There is decreased muscular tone, generalized muscle fatigue, slow or weak contraction. Also, there is constipation and due to reduced GI motility, anorexia due to that is the lack of appetite is also there. It is associated with pain in the abdomen. Then peptic ulcer development, possibly due to calcium stimulation of gastric acid secretion. Then cardiovascular effect of the hyperparathyroidism are depressed diastolic relaxation due to impaired heart filling. In some cases, hypertension or arrhythmias are also developed. The parathyroid poisoning or hyperparathyroid crisis represent a medical emergency due to the massive overproduction of parathyroid hormone, leading to severe hypercalcemia, and calcium level become more than 17 milligram per deciliter. So there is rapid calcium mobilization from the bone due to intense osteoclastic activity. kidneys are overwhelmed, so they are unable to excrete calcium phosphate efficiently. So, consequences of supersaturation will result, and excess calcium and phosphate will result, and CaHPO4 crystal deposition. Uh, and these crystals precipitate in soft tissues, leading to metastatic calcification. In the lung, they are precipitated in the alveoli of the lung, so there is impaired gas exchange. In the arteries, there is uh, defective function of the vessel walls, so elasticity will be reduced and result in hypertension. The kidney will show the tubular damage, and this will result in acute renal failure. The thyroid gland and stomach mucosa is also disturbed, and there is interference with the glandular and acidic secretion. So, finally, without immediate treatment, the systemic calcification can cause death within days. In hyperparathyroidism, kidney stones are common and significant complication due to sustained hypercalcemia and an increased urinary calcium excretion. Elevated parathyroid hormone will lead to increased calcium and phosphate release. Excessive parathyroid hormone causes bone resorption and increased intestinal absorption of the calcium and phosphate. So this will result in elevated plasma calcium and phosphate level, and to restore the balance, the kidney they excrete more calcium and phosphate, and urine becomes supersaturated with these ions. So in concentrated urine, calcium salt precipitate, and they form calcium phosphate stones, calcium oxalate stones with normal oxalate levels. This risk is especially worse in alkaline urine, where calcium salts are less soluble. So many patients with mild hyperparathyroidism, they have fewer bone symptoms, no overt hypercalcemia symptom, but develop recurrent kidney stones. So to manage, acidic diets or acidifying agents like ammonium chloride or cranberry juice help by lowering the pH of the urine and improving the solubility of the calcium salt, reducing the stone formation. So this picture is summarizing the effect. The hyperthyroidism will result in increased parathyroid hormone. So this inappropriate secretion of the parathyroid hormone will result in increased calcium and phosphate ion in the blood, and these are coming from the bone, and they are going to form an alkaline urine, and this alkaline urine favors the stone formation. So this increased pH of the urine should be decreased, otherwise there will be precipitation of the stone within the kidney. So this is decreased by use of acidifying agents. Secondary hyperparathyroidism is a condition where high levels of the parathyroid hormone they occur as a to the compensatory response to the hypocalcemia, not due to an intrinsic abnormality of the parathyroid gland. The key distinction from the primary hyperparathyroidism is that this primary hyperparathyroidism is associated with hypercalcemia caused by abnormal parathyroid gland function, while secondary hyperparathyroidism is associated with hypocalcemia triggering increased parathyroid hormone secretion as a compensatory mechanism. The causes are vitamin D deficiency that reduces the calcium absorption from the gut, and this lead to hypocalcemia stimulating parathyroid hormone secretion. And another cause is the chronic renal disease. So damaged kidney fail to produce adequate 1,2,5 dihydroxycholecalciferol, that is the active form of vitamin D, and this reduces calcium absorption and disrupts phosphate balance, contributing to hypocalcemia. So vitamin D deficiency will result in decreased calcium absorption, hypocalcemia, and increased parathyroid secretion. And increased parathyroid secretion will result in increased bone resorption from the due to calcium mobilization from the bone, and in the long term the bones are weakened. So as a consequence there is development of osteomalacia, and this is inadequate mineralization of the bone due to vitamin D deficiency, and the bone becomes soft and prone to deformity. So there is bone resorption due to persistently elevated parathyroid hormone, and the this increases the bone breakdown to restore the calcium levels in the blood. So this picture is summarizing this effect. The calcium is decreased. So as a compensatory mechanism, there will be increased parathyroid hormone release from the parathyroid gland. So one cause is vitamin D deficiency due to chronic renal disease. There is the conversion problem. The active vitamin D is not formed, so the calcium is not absorbed from the intestine. Another effect of this is osteomalacia. There is resorption of the bone. Thank you for watching this video. If you have any query, please write in the comment box.